Go for it. All right. All yours, sir.
Thanks, Carly. Appreciate that. Well, good afternoon, everybody. I assume most of you are either in North Dakota or else in Central Time. But as Carly had mentioned, my name is Dr. Erik Reis. I'm a chiropractic functional neurologist at the Neural Connection, which is our clinic in Edina, Minnesota. I was born and raised in North Dakota. I was born and raised in Bismarck. So I haven't traveled too far away from my hometown, and I still have all my family there. So North Dakota is always near and dear to me. And more importantly, too, the reason that we're all talking about this is because um, it's something that I've not only lived through, but I've also been fortunate enough to be a part of people's care and treatment with helping them overcome concussions, brain injuries, and everything in between. So I have a set of slides that I'm going to share and I'll walk through. Everyone asks, can we have access to the slides after the recording? Absolutely, you can. I have my contact information on there as well too, if anybody wants to reach out, ask follow-up questions, or just have a conversation. The way I like doing my presentations and lectures is I don't want to just speak at all of you for the next hour or so. I want it to be kind of a give and take back and forth, and I want it to be a conversation. I think that neurologically speaking, that's actually how we learn, is that we get to have conversations and challenge our thinking and be able to add comments and cue kind of ideas. But more importantly, too, I want people to get a lot out of this. You can all go read the articles and the journals and all the peer review research coming out. But I think it's really exciting for us to be able to have discussions and conversations, even though we may not be in the same room. So, Carly, what I would ask is if somebody does have a question and they post it in the chat, I would actually prefer to answer that question at that moment versus me moving on and having to go through that. So, as we go through the session, please by all means ask questions, regardless of how, important or how silly you may think it is. I promise you, if you have that question, there's probably a lot of other people that do as well too. And we can kind of go from there. So I'm just going to go ahead and share my slides. Carly, what I would ask, I guess, is just to make sure that you can actually see those. So let me just share my screen really quickly. Just bear with me for 1 second. And then, Carly, can you just give me a verbal if you can see my notes and my slides?
You're good. Nope, we're not seeing your notes. We're seeing presentation mode.
Perfect. Great. Awesome. So today we're going to talk about why the eyes are a window into the brain after a brain injury. For some of you, this may be very intuitive. For others, it may be something that might be a bit surprising for you. Um, People always ask the question like, why am I passionate about treating concussions and brain injuries? Well, for better and for worse, I saw what the neurological and neurodegenerative outcomes can be within my own internal family. So I lost my grandfather to Alzheimer's and cancer in 2014. My middle name was named after him, and he was an amazing human. And that was probably one of the hardest things for me to witness, especially because he was living in Bismarck at the time, and I was actually in the middle of graduate school. And so I got to see the massive gaps in time, whereas my family got to see him over days, weeks, and months. And one of the most remarkable moments for me was when I was actually doing some of my neuro rounds in Oregon when I was out there. My brother had called me and said, "Hey, I got some bad news," and he was in tears and he was crying. I was like, "Kyle, what's going on?" And he goes, "Grandpa forgot how to do the Rubik's Cube. He actually forgot what the Rubik's Cube was." And that really hit home for me because my grandfather prided himself on teaching his grandchildren how to do the Rubik's Cube. And I think it's those pivotal moments like that, for those of you who have been impacted directly or even indirectly as providers, those are the moments that really stick with you and really provide the why. Because for me, what I've realized is that I'm not perfect. And, the things that happen in my life are actually going to have an impact on the rest of my life. I grew up in North Dakota playing ice hockey and soccer, football, as they would say in the UK. And I've had concussions. And unfortunately, not only have I experienced them firsthand, but being a patient first and then a doctor second, and now a massive advocate third, has completely changed the way that I look at treating concussions and brain injuries or any other neurological condition. Because what I realize is that there are a lot of patients who have unfortunately been failed by the system. Now, I believe that there are a ton of great doctors out there and people who want to help, but sadly, sometimes these patients get left by the wayside. If they're responsible for follow-up and they have memory issues, good luck trying to get them to remember to be able to follow up on their own. There are instances where I think we can do a better job, and I'm optimistic technology can help, but by empowering us and empowering ourselves and patients to be able to be on the same team, I really think there's a way to help a lot of people in this arena, in this category, because I think we all resonate with this. We all want to live a life of zero regrets and zero limitations, and I think that that's actually possible. Um, when we're dealing with the populations of individuals who've had concussions and brain injuries, and I will use those synonymously, what we're really talking about is we're talking about some sort of outcome that happened with regards to the brain. And I love this photo of the brain. This is a sagittal slice of the brain, which is essentially would just go straight down my face and forehead and kind of opening the brain up, almost like a walnut or a cantaloupe in half, right? And so when we think about a concussion or a brain injury, we're thinking about the brain and we're looking at it and we kind of imagine this brain as this beautiful gelatinous substance that is full of these things we call neurons that allow us to do things that we attribute to humanity, like have conversations and thoughts and emotions and navigate our world. But what I think is really interesting about the brain is that it doesn't actually just look like this. It functions like this. It functions like a massive computer within multiple computers in all of these different neural hubs that integrate and communicate and have conversations back and forth. And this is really relevant for us when we're dealing with brain injuries. Regardless of the severity of the brain injury, this is a really important aspect. Now, whether it's a quote unquote mild traumatic brain injury like a concussion, or it's a severe brain injury, or we have an open wound and now we have bleeding and hemorrhaging, or maybe we even have other opportunities or other issues that are going on neurologically, this is actually what we're dealing with. We're dealing with circuits and circuits that communicate and have conversations at all times throughout the day. Maybe it means to give a green light to a circuit, or maybe it means to give a red light from excitation to inhibition. But at the end of the day, this is what we're talking about. And what happens when you have a brain injury, and specifically when you have a concussion, for lack of a better term, is that in some way, shape, or form, this brain twists and shears and rotates on top of itself. Now, the hardest part about treating these injuries is that we can't tell you exactly where the injury is going to happen. And the way I equate that to my patients is I tell them, listen, you having a concussion or a brain injury is kind of the equivalent of me pouring water on my laptop. I can't tell you which circuits, which systems, which functions are going to be lost as a result of that. Now, we can label this as diffuse axonal injury, but just because you get a hit to the left side of the temple doesn't mean that the left frontal lobe or left frontal temporal region is going to be affected. We know more, there's more to that story. And so, as we deal with these networks, what we're really talking about is dysfunction of the nervous system in some way, shape, or form. And I don't think any of these statistics are going to surprise anybody, right? So we have 1.7 million people annually sustain a TBI. I think some of the more important components of this are the fact that amongst all age groups, motor vehicle accidents are the third leading cause of traumatic brain injury. That's interesting to me. And I can't tell you how often we've seen patients who've been in small fender benders or even large fender benders, where they're now dealing with not only the structural issues that come, but more importantly, they're still dealing with things like brain fog, fatigue, dizziness. Maybe they're having things like digestive issues. Well, why would they be dealing with those issues? We're going to talk about some of those things because, and I mentioned this earlier, and I'm sure most of you are aware of this, but a concussion really is a mild traumatic brain injury. Now, I put that into quotations because what does mild actually mean? A mild injury for one individual could turn out to be a very severe injury for another, right? And so as we use those synonymously, what I really want to allude to is the fact that in some way, shape, or form, we have to understand that there's trauma to the brain and to the nervous system. Now, why this is essential, why this is relevant is that when I was playing ice hockey and soccer back in the late 90s, early 2000s, we used to think, oh, well, if you get your bell rung, you've got a concussion. If you know where you're at, and you know the time of day and you know what's going on, then you can just get back out there and keep going. We know a lot more today than we did back 20, 30 years ago. And what I'm going to tell you is that we also know that you don't actually just have to have a hit or an injury to the head or to the neck to sustain a concussion or a mild traumatic brain injury. I have patients who have fallen on ice, hit their tailbones, and they've sustained concussions as well too, right? So we have to actually understand that it's all of these forces and this trauma that's translated throughout the body, throughout the spine, and its net effect on what's actually going on in the brain and inside the skull. Classic concussion signs and symptoms. And once again, I'll use these synonymously with brain injury. And as we get to some more severe brain injuries, there's obviously things that will change based off of that. But what I want to allude to is I really want to paint a similar picture between concussions and what happens with whiplash associated disorders and post-auto whiplash. So classic concussion signs and symptoms, headaches, dizziness, nausea, visual changes, right? Mood and memory disturbances, cognitive disturbances, and even changes in attention and focus. But one of the biggest factors that I don't think we're doing well enough job in, and I don't think I was doing this years ago, was understanding how impactful sleep can be in the recovery, and more importantly, just the daily function of these individuals who are struggling with brain injuries. Sleep disturbances are quite common with this population. 30 to 70% of individuals, most likely even more, are having effects because of their traumatic brain injury. One of the hardest parts about this, though, is that unfortunately, what we know is that, and I don't know how many providers we have on here, but for the doctors in the room who have the patients who've come in and have had imaging, a lot of times the imaging is going to actually show up to be relatively normal for a mild traumatic brain injury or a concussion. Okay. As we get to the severe traumatic brain injuries and things like that, you're most likely going to have structural changes. But this is where we actually struggle a lot, is the fact that imaging is phenomenal for finding tumors, brain bleeds, venous malformations, proper structural changes in the brain that occur as a result of an injury. But the problem is, structure doesn't always dictate function in that category. Can you still have a patient who has a clean MRI or a CT still have post-concussion symptoms or mild traumatic brain injury symptoms? Absolutely. We see it all the time. It's kind of the equivalent of you going to take a look at a car and looking at the car from the outside, and maybe you pop the hood to see what's going on the inside, but you never get to drive it, right? You don't really know the functionality of that car until you get behind the wheel. You check to see if inputs match outputs. Does the AC work? Does the stick shift actually change gears? It's a really important component for us. And this is one of the reasons why I think we're kind of coming to a juncture where we're realizing that imaging is phenomenal and it's great, but just because you have normal findings doesn't necessarily mean that there's nothing wrong with that patient. Now, what's great about that is when you have clean imaging, you know that there's no tumors, brain bleeds, venous malformations, things along those lines, right? But what it tells us is that it tells us that there's probably more to the story. Now, this is really relevant for concussions and mild traumatic brain injuries, but especially for those whiplash associated disorders, right? So we mentioned that that's the third leading cause of concussions and mild traumatic brain injuries is auto accidents. Now, with whiplash, we're talking about the structural, the ligamentous, the tendinous outcomes that usually occur with people who are involved in auto accidents or any sort of traumatic experience that has an outcome with the neck. But I pose the question to all of us on here, and whether you're a provider or whether you're a patient, what do these patients actually present like? These are common signs and symptoms of whiplash or post-auto whiplash. Headaches, head and neck pain, dizziness, nausea, vomiting, visual disturbances, mood and memory disturbances, cognitive delays, and sleep issues. There's really no significant difference between those two. And what that tells me, as well as a provider, is it's saying that it's not just the trauma to the neck, but it's also the trauma to the neurological structures that occur as a result of that as well too. And this is why, once again, what we're finding is that even trying to diagnose whiplash via MRI or CT is clinically quite difficult. Now, unless you have absolute aberrant responses, you have significant amounts of inflammation, or you have proper injuries, you're probably not going to find much with that imaging. But does that mean that these patients aren't dealing with symptoms, structurally or even neurologically, potentially even metabolically? No. And that's really where the provider insight and that clinical experience really comes into play. Because when we take a look at what happens with a concussion, we've seen this before. This coup counter coup interaction where the brain sloshes and moves inside the skull when it's suspended in that cerebral spinal fluid. But what's the difference between this photo and this photo of looking at whiplash? The only major difference is the fact that with the coup counter coup concussion, we're looking at the brain, and in the whiplash, we're looking at the neck. But here's what I'm going to tell you is that you can't disconnect any of those systems because they're all hardwired and they're all really important and dependent on each other. And this is where things actually get quite interesting, okay? And I promise I'll bring vision into this conversation, but we kind of have to set ourselves up for understanding why these areas become affected. We know that there's a lot of data supporting the disturbances in pain processing after concussions and brain injuries. There's central sensitization that happens, not only in the tissues, but also in the spinal cord and in the areas of the central nervous system that actually inhibit pain going up through the spinal cord into the rest of the brain. We're having proper central nervous system changes that occur with these types of injuries. What I've found clinically, and what a lot of the research is also showing, is that we're most likely dealing with sensory mismatches. Well, what does that actually mean? The analogy that I give my patients to help them understand this is that if you had three friends that went to the same party, you would expect those three friends to tell you relatively the same story about that party, right? What time it was, who was there, where it was located. I'm always going to want to ask about what kind of food they had, right? But they're going to hopefully give you similar answers. The problem that happens and that occurs after a brain injury or a concussion is that those three friends can go to the exact same party, but they can tell your brain completely different stories. So who does your brain believe at that point? Well, in reality, right, we would just ask our best friend because we know they wouldn't lie to us. But the brain doesn't have that luxury. And the brain can't just open up a window to reality and say, okay, based off of these coordinates and what I'm seeing, this is actually what's going on. This is a really important mechanism for us to understand, is that we realize that there are a lot of processing issues that occur, and sensory issues can actually manifest to motor issues. Now, I'm going to kind of summarize those three friends that go to the same party, and there's obviously more to the story. You have more than three senses, but these are the three big players, especially with mild traumatic brain injury and concussions. Friend number one are your muscles and joints. Okay, we already talked about the neck, but what we were talking about is all the muscles and all the joints in our entire brain and body. Now, there's a reason that gravity is actually our friend. Gravity is always giving us feedback, and our muscles are always having to fight that gravity. And this is one of the reasons why when astronauts go to space, they can't stay for very long, is because they're not having that constant driving of their nervous system via gravity. And so you see them working out 3, 4, 5, 6 hours a day of exercise. They're trying to drive that brain to continue to have brain function. This is one of the reasons why we also base motor milestones off of young children's development. Motor milestones are a really important aspect for our neurodevelopment. So friend number one, muscles and joints. For those who are dealing with post-auto whiplash, concussions, and brain injuries, that's a really big system for us to integrate, okay? System number two, of course, are our eyes, right? Our eyes are a massive window into the brain, and we'll get into those as we continue to talk. And I'm not just talking about the eyeball. What I'm actually talking about is I'm talking about all of the visual components of the retina, all the way back to the occipital lobe, the brainstem, areas of the cerebellum, all of these areas that are heavily integrated with your visual interpretation of your world. And the third system is the vestibular or inner ear system. And this is the system that is a little bit older, phylogenetically speaking. It's a little bit more fragile. It's not that well developed. This is the system that allows us to have balance and integration of changes in gravity. So if I put everybody on this call and I threw you all in an elevator and I had you all close your eyes and not move your neck, and I put you up 20 stories, you all would be able to tell me that you moved in some way, shape, or form. This vestibular system is graviceptive, as they would say. And what that means is that it's sensitive to changes in gravity. These three friends are really important for us when we're dealing with concussions and head injuries because these systems give us feedback about our environment. But the problem is when they're not giving us the right feedback, not only is the input inappropriate, but more importantly, too, the output is inappropriate. And what we're seeing is that even with people who are having cognitive delays and memory issues, it's not just that the frontal lobe or the hippocampus isn't functioning very well. It's actually that the inputs from the environment are not accurate and appropriate, therefore leading to altered outcomes and altered outputs of the brain as well, too. It's the same thing as me checking a reflex, right? If I go check the L4 reflex, if I go check a patellar reflex, if I give an input with the reflex hammer, I should expect an output of a reflexive movement of the leg. It's no different than these sensory mismatches that we're dealing with traumatic experiences of the brain. And that's really important for us to remember because does that change the way we view our therapies? Possibly. Just because somebody has memory deficits doesn't mean they need to work just on memory. Maybe they have different paresthesias or different issues with the sensory processing. What we actually know is that your vestibular signals are really important processors, not only for changes in gravity, but they're also really important for tactile feedback. Okay. And if you take a look at the photo on the left, what you're going to notice is that the vestibular nuclei integrate all these different aspects of the three friends, but they have a massive outcome and output into the thalamus, this big filter that takes things and filters things up to the cortex. And we also know that in some way, shape, or form, the vestibular system can actually sometimes weigh these cues heavier when there are conflicts with other sensory mismatches. Really important, really interesting to consider. Okay, we talked about the head and we talked about the neck, but we know that changes in cervical spine input, these muscle spindles, they have a high density in the base of the skull, especially over the suboccipitals. And what we know is that those changes can actually yield changes in vision. So for those of you on this call, I actually want to just give you a really quick brief, but I think it's quite impactful example. I want you all to take your fingers and I want you to put them on the back of your skull back here, where 90% of your patients coming in are going to tell you that they have these chronic tension headaches that they're dealing with, okay? So I want you to put your fingers on the back of your skull on both sides, but I don't want you to move your head at all, okay? All I want you to do is palpate your suboccipitals, and I want you to move your eyes left and right and forward and back and up and down as fast as you can for the next 10 seconds. Okay? So in the comments, how many of you felt your suboccipital muscles move based off of your eye movements? Okay? We should. Okay? All of you should. And if you didn't, try it again. Here's what I'm going to tell you. And this happens over and over and over again. Patients who are dealing with neck issues after a concussion or a brain injury, everyone's looking at the neck, they're looking at the neck, and maybe a lot of them are getting the other visual therapies as well too. But if you don't look at the eyes, and if you're somebody who's dealing with chronic tension headaches, and nobody does a proper visual examination with you, we know the impacts of the neck and the eyes and how they integrate together. What's beautiful about this is this kind of changes the way we actually look at the neck and the visual systems as a whole. But what's amazing about it too is that we know that this happens quite often because your eyes truly are a window into the brain. We've known about this for decades. Neuropsychologists, neuropsychiatrists have known about this for quite some time. For those of you who are familiar with EMDR therapy, well, what is this actually doing? You're utilizing the eyes, which manifests and have an outcome of the frontal lobe, the pons, and the cerebellum, and you're using it in some fashion to allow people to re-engage and lay down different pathways about memories, specifically aversive memories that they're dealing with. The eyes truly are a window into the brain. And this is why, right? Your visual system gives us so much information about our world around us. But there's two different aspects to the visual system, all right? So you have the peripheral visual system, which is things like the eyeball, the cornea, like the iris, the lens. These are things that an optometrist, for the most part, would be looking at, all right? But then you also have the central visual system, which is genuinely everything from the retina all the way back to the back part of the brain and even into the brainstem. And this is really what we're actually trying to treat when we're dealing with concussions and brain injuries. All right. We're looking at the neurological software that is no longer integrating as well with the hardware. Now, if you have an astigmatism, if you're nearsighted or farsighted, if you have a corneal problem, I can't touch that. And that's not my job. That's a great reason to refer somebody to an optometrist or a neuro-ophthalmologist if needed. But if you're a visual therapist, or if you're a rehabilitation therapist, or if you're doing things with people on a structural level, what you have to understand is that there are a lot of software components that are impacted by concussions and traumatic brain injuries. Okay. And this is why, and I think this is just a really interesting kind of aspect to it. Everyone thinks of the eyes as this, component where we can see things visually, right? But the eyes give us so much information about our environments. And we're going to go through why that is. It's mostly because it gives us a lot of feedback about our environment, right? If I was in the room with all of you and I made a quick jolt or a quick jaunt at you, a lot of you might have your pupils get a little bit bigger. Some of you might see your heart rate increase. You'd have a sympathetic or a stress response based off of that. Well, you couldn't have that if you weren't able to see me actually doing something. Having your brain tag that as a response And then more importantly, too, have an appropriate reaction to it. The visual components after a traumatic brain injury are really important. And lo and behold, they're held down in that lovely brainstem, where all of these things kind of are controlled in your brain and body that you don't really have to think about, and you shouldn't, right? So if you take a look at your brain, and your brain as an analogy is essentially kind of built like a house. If you and I decided to build a house, the first thing we would do is we build a really stable foundation in that house. And in that house, we would put things down there that we need, but we don't want to have to think about. These are things like plumbing, heating, electricity, sewage, right? Basic things for the house to function. Well, in the brain, you have similar analogies. You have things that regulate your blood pressure, your heart rate, your gut functionality. Basic things that you shouldn't have to think about. But what happens after a brain injury is that some of these lower areas of the brain become affected. And now, metaphorically speaking, if you have the foundation of the house, we stack layers on top of that house, and most of us live in the frontal lobe and the cortex, the VIP suite, as I would say, right? We all live up there and we have our thoughts and our beliefs and critical thinking and all of those things. But the problem is, if there was flooding down in your basement in your actual house, you wouldn't just stay upstairs. You'd hire somebody to take care of that and put that out. You would take resources and you allocate bandwidth to go and tackle that. The same thing happens for the brain. And so when these lower areas of the brain become affected, well, lo and behold, the higher centers don't get priority anymore. And what we actually see is we can see things like brain fog being caused by visual issues. We can see things like fatigue being caused by visual issues. Maybe patients are now getting things like nausea, digestive distress, things along those lines. It's because of this lack of integration, but more importantly, too, if the foundation of the house is no longer serving us, then the brain's going to go back to these lower areas to try and figure out how it can continue to survive. So when we're talking about visual issues that happen with a brain injury, remember, we're not talking about the hardware, although you can have an injury to the eye if it happened. We're talking about the software, all right? And these are actually some of the most common things that happen following a traumatic brain injury. And we'll go through them one by one, all right? Visual fixation is this basic process of your ability to keep an eye on a stable position and holding that position to center over the fovea in the back of the retina, right? This visual fixation is actually controlled by the brainstem, and it's a really important aspect for us because you spend somewhere around 80 to like 85% of your waking day fixating your eyes on targets. You have to. Your brain is interpreting your reality and your world based off of that. What happens with a brain injury or a concussion is that these visual circuits no longer do their job as well. And you're going to see this kind of depiction of the brain and of the eyes over and over again because it's really important for us. Your eyes need to stay steady on a target. And that's not just staying here where you're stationary and being able to keep your head here. But what's the first thing your patient's going to do if they're able to walk out of your office? They're going to walk. Well, what happens when you're walking? You have a subtle movement of the head and the eyes back and forth, where now you're having this yes, yes movement of the head, and your eyes have to be able to have the exact opposite movement to maintain visual fixation. That's a basic vestibulo-ocular reflex, right? And so if these things become dysfunctional and affected, good luck trying to get them to do any more complex visual therapies or exercises. Visual fixation is ground zero for 90% of the patients walking into my office who have issues with traumatic brain injuries. After visual fixation occurs, we look into these things called smooth pursuits. So visual fixation is looking at my thumb. A smooth pursuit is literally tracking the eyes back and forth on a target that's moving. Think of like watching a bird fly off into the sunset. Your eyes have to be able to track that. Your eyes are tracking a moving target. This requires attention. This requires anticipation of where the target's moving, and also requires working memory. But here's the problem. 60% of patients with traumatic brain injuries, specifically mild traumatic brain injuries, I would argue this gets worse with more severe brain injuries. 60% of those patients had abnormal pursuit eye mechanisms. Well, of course they did, right? These areas of the brain where these pursuits are generated and regulated are really impactful for our environment. And it's the same mechanism, right? So we see these areas not only in the midbrain, but we also see it in the pons, these cranial nerves 3, 4, and 6, this medial longitudinal fasciculus that allows our eyes to stay yoked together and move back and forth in conjugate mechanisms. These are really important aspects for us. Because once we get to fixation and once we have visual tracking, then the next step for us is to look at fast eye movements. And these are what saccades actually are. These are fast eye movements, which are used to point your eyeballs to centralize your fovea onto a target of interest. These need to be accurate, they need to be fast, and they need to have really short latencies. Because if it takes a long time for your brain to generate these eye movements, your environment in some way, shape, or form has probably already changed. So you're consistently or constantly behind the eight ball. Now, we know that there are cortical and frontal lobe regions that are responsible for initiating and mediating saccades. There's a ton of real estate involved with the midbrain, with the pons, and actually with the cerebellum as well too. But the top three ones are the frontal eye fields, this dorsolateral prefrontal cortex, and then that cingulate eye field. Now, these are really important areas for us because, as I mentioned, if you can't fixate on a target, good luck trying to have a pursuit. And if you can't pursue something, good luck trying to create a saccade. These are the patients, maybe they've had a brain injury, or maybe they haven't, and they've been labeled with dyslexia or ADHD. And these are the kids where they can't hit targets with their eye movements. But they say they can't read well, they can't comprehend well. There's probably far more to the story than that. And what I'm going to tell you is that all of these are different mechanisms for you to actually do bedside testing with. So if you have a patient in your office, can they look at your thumb? Can they actually track that thumb going in the horizontal or vertical plane? Can they do the H pattern as well too, right? This is a classic oculomotor test that we would use. More importantly, too, can they look at things? Like if I flick my thumb, can they actually look at the thumb that I flicked? Do they hit it? Is it accurate or is it delayed? And then we can actually test the opposite. So don't look at the thumb that I flick. Reflexively, your brain wants to go and move over and have that shiny thing kind of moment. But these anti-saccades are really powerful mechanisms as well because they actually give us a determination of the integrity of the dorsolateral prefrontal cortex. This is an area of the brain that's really hot right now where we're talking about things like depression, PTSD. Now, these areas are not functioning as well as they could be when you're dealing with those types of mental health issues, but they're also quite prominent for individuals who are dealing with concussions and brain injuries as well. Now, you as a provider don't need to know this picture, okay? But I wanted to show you that eye movements really aren't very simple to begin with, right? There's a lot of real estate in the brain that's involved with generating saccades, visual fixation, pursuit mechanisms, and don't forget about the cerebellum, because the cerebellum isn't just there for fine motor movements, balance, and coordination. There are areas of the cerebellum that are involved with autonomic function. There are areas of the cerebellum that are involved in emotional regulation as well, too. There are areas of the cerebellum that are also involved in sleep. So we thought we had it all figured out. And then, of course, more research came about. Now, in our office, what I love doing is I will always do a bedside examination because I want to see what I see in front of the patient. But I use a ton of video oculography, also known as video nystagmography. What we essentially do in the clinic is we put goggles on patients and we actually objectively graph out their eye movements based off of this. So if you take a look at this video right here, or this photo, there's an objective line, and I wish it was a better color, but it's a blue color in the background. The blue line is actually the gold standard of what should be happening with the eyes. All of these little kind of sawtooth jumps, like shark tooth patterns, are the eyes actually having a little bit of a moment where they're actually not able to fixate and follow. We can objectively quantify these eye movements. We can use them as a great report of findings for patients, but more importantly too, we can actually track progress based off of these different tests. Now, these are powerful ways to keep us honest as providers, but it's also a great way to show patients what's actually going on with them. Because I think a lot of patients come into the clinic feeling as though they don't really know what else is going on, or doctors that they've seen in the past haven't been able to figure out why they still feel the way that they feel. And as they understand these mechanisms, no more importantly, they understand they can actually see their eyes. We can use these objective measurements and these tools as a way to help patients not only become educated, but to show them progress over time. And that's what really is exciting for me, is that I think moving into the digital age, we're actually able to quantify these things, justify reimbursements, and more importantly, to showcase that there is progress being made with these patients. I kind of want to go through and talk just a bit more about some of the other aspects that happen. As much as your eyes are a window into the brain, we know that trauma affects your neurons. Lo and behold, that should not be something that's earth-shattering for you. But what does it actually do? Well, these neurons, they twist and they shear and they rotate on each other, but it's not just the shearing or tearing of the neurons. And a lot of times it's these secondary and tertiary inflammatory cascades. It's these inabilities for these cell membranes to actually maintain their cellular integrity. And so these membranes might be a little bit closer to threshold. Maybe now you're touching the neck or you're touching the arm and they feel a little bit painful, but there's actually no damage to the tissue itself. The nervous system has become primed. And what we know with a brain injury is that you actually have changes in the coupling of blood flow and neurological integrity. So, for instance, if I have everybody right now move their right arm in a complex figure eight movement, if I shot an MRI of your brain right now, what I would see is I'd probably see your right cerebellum and your left frontal lobe probably light up like a Christmas tree on that MRI. Okay. What's going on is you're having an increased amount of blood flow and an increased amount of neurological activity coupled together, which makes sense, right? If you're using your neurological bandwidth, you need more blood flow to take out metabolites, bring more oxygen, and bring more nutrients to that area. Well, what happens after a brain injury is that those areas actually become decoupled. What we can see is that those activities, the activity of the brain, you'll see neurological activity, but you'll see a decrease in blood flow. Now, the problem with that is that you just decoupled a really important mechanism for brain function. We know this happens with patients who have things like POTS, postural orthostatic tachycardia syndrome. This happens with people who have like chronic dizziness and fatigue. These are really important components that we know, statistically speaking, are probably going to be affected after a brain injury. And it's one of the reasons why we're having people now, especially after concussions and mild traumatic brain injuries, get back to walking and doing low-grade cardiovascular activity as quickly as possible, within reason, within threshold from an autonomic perspective. That coupling of blood flow and neurological function is really important for us. We also know that trauma affects the autonomic nervous system, right? The basement level of the house that I was talking about earlier. Things like taking out the day's trash, the sewage, the plumbing, the electricity, all of those things that your brain has to take care of. We know that the autonomic nervous system is impacted, and this system essentially affects every organ and every tissue throughout the brain and body, which is why you can have an injury to the head or to the skull, and you can have metabolic outcomes. You could have changes in blood flow. You can have altered sensations in areas that may or may not have been directly affected by the brain injury. Now, when you look at the autonomic nervous system, you have two systems, right? The sympathetic and the parasympathetic. The sympathetic is the fight or flight or freeze response. The parasympathetic is the exact opposite, right? The rest and digest. Now, these are two very different systems, but they're always in tandem and they're always on. They're like two younger brothers always fighting back and forth, right? They're the yin and the yang. And unfortunately, what happens is people with traumatic brain injuries usually default into the automatic sympathetic or fight or flight responses. Well, that changes things. It changes things to their blood flow to their gut. It changes things like blood flow to their peripheral tissues. It can alter their immune function as well. One of the biggest issues with an acute brain injury is the fact that these people don't just have issues with the brain injury, but a lot of times their immune system goes into such shock that a lot of them actually don't survive based off the fact that they get opportunistic infections that actually take over their nervous system, causing those issues for them. That's interesting. What we know is that there's some interesting research going on right now with helping people get out of that delicate balance of being sympathetic dominant and getting their parasympathetic system back online. And everyone's talking about it these days, the vagus nerve. Well, what does the vagus nerve actually do? The vagus nerve is your 10th cranial nerve. It comes out of your medulla, and it actually consists of 80% sensory neurons and 20% motor fibers. So what that means is that 80% of this nerve is actually getting information in from your gut, from your environment, from all around in your abdomen. And it's essentially giving your brain information. It's a super highway into the brain. Only 20% of those nerves are actually going out away from the brain to those organs. What's interesting is that vagal nerve stimulation has some potent anti-inflammatory mechanisms. And here's what they're looking on doing and using vagal nerve stimulation for: treating things like autoimmune conditions like rheumatoid arthritis. They're looking at using vagus nerve stimulation for treating things like depression, anxiety, PTSD, migraines, cluster headaches, concussions, and brain injuries. And this all started with the story about how they found it with seizures. The vagus nerve, we still don't know very much about it. And I promise you, in the next 5 to 10 years, this will be one of the hottest topics of discussion because the vagus nerve affects everything from here all the way down to your belly button and most likely affects other areas that we're not even looking at. What's interesting with how this actually has influence is it's not just neurological function. The anti-inflammatory parts are kind of threefold of what we know today. The first one is that the vagus nerve can actually impact the hypothalamic pituitary adrenal axis, okay, the HPA axis. It can pump out acute releases of cortisol, which can actually be very beneficial, right? If you have an injury to your knee and you get a cortisone shot, that's a great thing because it can have an anti-inflammatory response there. The problem is you can't have multiple cortisone shots in a row because what it does is it degrades tissue. And chronic release of cortisol does the same thing to your nervous system, your brain, and your body. So these acute bouts of cortisol are actually a little bit beneficial for us, whether it's in the environment or whether it's because of vagal nerve stimulation. But the other two responses are quite interesting, okay? So you have a cholinergic anti-inflammatory pathway, which is actually acetylcholine being released at the synaptic junction of the vagus nerve onto an efferent organ. It binds to these alpha-7 nicotinic acetylcholine receptors on macrophages, immune cells. So you have a neurotransmitter binding to these alpha-7 nicotinic receptors on a macrophage, and it inhibits one of the most potent inflammatory mediators, tumor necrosis factor alpha. That's interesting. The same thing happens, though, with the splenic sympathetic anti-inflammatory pathway. So in some way, which doesn't make sense to me yet, the vagus nerve stimulates this splenic nerve, the splenic sympathetic nerve. Norepinephrine is now released, and it binds to these same receptors, which inhibits tumor necrosis factor alpha. Now, in my mind, that doesn't make sense. But what I'm going to tell you is that there's still so much that we have to learn about vagal nerve stimulation. What's amazing about this is we know that the vagus nerve is sensitive to pro-inflammatory cytokines like interleukin-1 beta, interleukin-6, and tumor necrosis factor alpha. We also know that when you stimulate the vagus nerve, it can suppress the production and the release of those exact same pro-inflammatory mediators. So it's chicken or egg. Which one works better or which one works more efficiently? We still don't really know. Because it's not just neurological function that we're talking about. We're also talking about the neurochemical and the metabolic cascade that occurs as a result of these things. Your mitochondria directly and indirectly become affected because of this inflammatory cascade that occurs. And all of these voltage gate and potassium and sodium channels start opening up. You have leakage of different ions across cellular membranes. Maybe that means that a cellular membrane in your hippocampus doesn't come to threshold as well, so you can't form short-term memories, but that the synaptic pathway in your amygdala is really close to threshold. And now every time you fire that, it's easier and easier and easier to fire to a point now where you are so stressed and you're so anxious that your brain just won't shut off. These are the neurological, chemical, and inflammatory pathways that can occur within individuals. We also know that these inflammation pathways are responsible for things like inflammaging and chronic aging. And it's some of the same players that we're talking about. C-reactive protein, interleukin-6, at points fibrinogen, but we know interleukin-1 beta plays a role with this as well. And so we're not just talking about neurons. What we have to realize is that these mitochondria are really, really important for us because they're the reason why those neurons can fire and wire and form new connections. They're the reason why your immune cells are able to do their job or why they're not able to do their job. And as we talk about it, and as this comes into play, what we know is that there's a lot to be said about the gut-brain and brain-gut connection. I cite this study in nearly every lecture that I give because I think it's so impactful. Now, we have to take it with a grain of salt because this was done in rats, all right? But this was published in 2009 in the Journal of Neurotrauma. And what they essentially did is they created a traumatic brain injury in these rats. And then what they did is they did a sagittal slice of the intestinal tract of these rats. So the top photo is what a normal GI mucosa should look like. It should be thick. Think of it like the castle walls to defend your castle, right? It should be thick. It should have a lot of villi. It should have a ton of surface area for absorbing nutrients. But within 6 hours of a brain injury, the mucosa went from picture A on the top to picture B on the bottom. Intestinal permeability, disconnecting immune functionality, the gut-associated lymphatic tissue has now become affected. Blood flow inevitably probably has changed. The ability to keep out viruses and bacteria and parasites and undigested foods is probably becoming altered. And now what we have is we have altered gut function, which probably is going to manifest as altered brain function. Are there patients that come into my clinic where they've had issues with food sensitivities and they have visual disturbances? Yes. Are there people that come in now who have autoimmune conditions, food sensitivities, right? Chronic inflammation in their digestive tract based off the fact they had a traumatic brain injury? Absolutely. And unfortunately, this isn't really common knowledge. Because what we know now is that when the gut becomes affected, the blood-brain barrier also becomes affected. These gap proteins, occludin and zonulins, are the same gap proteins in the gut as they are in the blood-brain barrier, which is the most tightly regulated barrier in your entire body. And once you have an immune response coming and those barriers become penetrated, now you have all of this production of inflammation, glutamates, the glutamatic cytotoxicity, mitochondrial dysfunction, and all of those pro-inflammatory cytokines that we were talking about earlier. So, what do we do about it? Is the question I always get, right? What does it look like to actually treat and rehabilitate the brain? Here's what I'm going to tell you. If I had it all figured out, I'd probably be telling everybody how to do it already, but I don't. And I don't think anybody really knows fully exactly what to do with every single patient that comes into their clinic because every single brain is different. Now, yes, do you have a high probability that your cerebellum is connected to your frontal lobe? Absolutely, you do. But I could get 20 concussions or 20 brain injuries with the exact same vector or the exact same forces, and I'd have to take a different approach for every single one of them because the brain is complex. If you take a look at this photo, right, just basic functionalities, there's so many reciprocal feedback loops within the brain. And this is a really important aspect for us. But how do we actually help people update their software? This is a question that I always get. And this is what I tell patients that we're actually trying to do is my goal is to help you update your software. And whether that's doing things structurally, neurologically, metabolically, or even like psychologically, because it's a yes and conversation. We know the brain needs three things for sure without a doubt. Okay. The first and foremost is fuel. For the most part, that's going to be blood glucose, right? Blood sugars. Well, what happens when our patients are diabetic or they become diabetic as a result of their brain injury? Does that change the way neurons fire and function? Absolutely, it does. We know that the brain needs fuel in some way, shape, or form. Ketones are a great option as well, too, but that's not always an option for everybody. So we need one, we need fuel, right? Two, the brain needs oxygen. Without oxygen, you can't live for very long, okay? But what's interesting with that is Carly was alluding to this earlier, is that we're looking at hyperbaric chamber tests and therapies as a way to help people overcome their brain injuries. I think it's promising. I think the research has still a long way to go to showcase that, but I think it's a really interesting area of focus. Can we get people to maybe breathe a little bit better to have them have better quality of life? That's an option too. The third and final thing that we all need, regardless, no matter what, is activation. You're always fighting gravity, therefore your brain's always getting feedback, and that's a great thing, but driving the brain, giving you sensory inputs, driving the eyes, the inner ear system, and all these things are really important for us. Okay. And what my goal is my goal is to get my patients back to function, right? My whole goal and focus as a chiropractor and also as a functional neurologist is to say, listen, how can I functionally get you from here to here in a way of helping you adapt your brain, change your brain, and promote neuroplasticity as much as possible? I'm not saying you can completely 100% reverse what happened, but are there ways of using and understanding the human nervous system to help people update their software? What I'm going to tell you is yes, there is. And what's exciting about that is that we've known that the brain can change for quite some time, right? We used to think that once you go through puberty and once you kind of have maturity of the brain, your brain stops changing and you're kind of set the way that you are. But what we now know is that you possess neuroplasticity until the day you get called upstairs. That's the reason why when you're in your 60s or 70s and you want to start playing guitar or learning how to like how to knit, you can start doing that and you can get better and better and better at it, right? For people who have a brain injury, they might want to regain their ability to walk again. Maybe they want to regain their ability to hold down a stable job. To be fair, it doesn't matter what the outcome is. What we need to understand and figure out is the fact that the brain does change, but it's not always for better. Talk to somebody who has anxiety or PTSD. That's neuroplasticity in the brain, promoting neural pathways and neurological integration and a pathway that's not serving that patient. Talk to somebody who has chronic pain or chronic regional pain syndrome. You have sympathetic windup of the autonomic nervous system now propagating pain to areas that were no longer affected. So neuroplasticity is our friend when we use it correctly. And that's the whole goal, right? We know that there are things that can positively impact our ability to form new connections. That's diet, that's lifestyle, that's anti-inflammatory mechanisms, but that's also things like learning, using your brain and body, different things, different mechanisms that are going to challenge your brain. Here's what I'm going to tell you is that every single one of you on this call today who is a provider, you are a receptor-based individual. So regardless if you're giving medications, if you're doing hands-on therapies, if you're a psychotherapist and you're talking to your patients, every single thing is going to affect your patient's brain in some way, shape, or form. The goal for you is to figure out what that outcome is and how you can utilize that. What's exciting to me about the visual system and about brain injuries in general is that we're looking heavily into the brain and looking at the eyes as a mechanism to assess brain function and also treat brain function as well. We know that visual rehabilitation can improve balance. Working on things like saccadic eye movements, pursuit eye movements can actually improve people's balance. Well, that makes sense now when you understand the fact that those three friends go to the same party and they have to tell you the same story. Maybe that means that the cerebellum functions a little bit better, or the vestibular system actually knows what's going on in the environment. We also know that vestibular rehabilitation is really important for people, not only with massive brain injuries, but with mild traumatic brain injuries with concussions as well too. All of these mechanisms play a role within themselves. And what I'm going to tell you is humans are visually dependent. Take away vision, and you're taking away a lot of the information from our environment. And this is why it's so important for us to understand that the eyes really are a window into the brain. But what are some other things we could use in our clinic or in our office to help people upregulate their software? Well, if everyone tips to being sympathetically dominant, we can always try doing things to upregulate vagal nerve integrity. And this is a patient of ours who's given me permission to use their photo, by the way, where we do a lot of vagal nerve stimulation with patients. Now we're using laser over abdomen, we're doing vagal nerve stimulation over her tragus of the ears, but things like belly breathing, singing, humming, using different aspects can actually have really important outcomes for optimizing the vagus nerve. Another really cool tool that we've been using lately is a thing called the Gamma Core. So this is actually an FDA cleared device for migraines and cluster headaches. I'm relatively certain they just got clearance for anxiety and PTSD, potentially in Canada or over in Europe. This is a really simple device that we can give patients and use in the office right over the left carotid artery, which is where the vagus nerve actually wraps around. Now, you don't have to do all of this stuff because in some way, shape, or form, light therapy could also be beneficial for your patients as well too. We know that circadian rhythms in the brain are really important for sleep mechanisms. We also use light therapy as a way to help us optimize and upregulate our patient's brain and nervous system. What's cool about light therapy, it's whether it's near infrared, LED, or even laser, is we know that it can actually upregulate mitochondrial function. It can increase the production of ATP, which is the rate limiting mechanism for our cells to be able to stabilize those neurons, upregulate our brain's productivity, and allow our cells to fire and wire in an appropriate way. What excites me about this is that when you look at like low-level laser and what Erconia is actually doing, these can actually have anti-inflammatory properties. They can promote beneficial neurotrophic factors, and they can actually upregulate these different synaptogenic mechanisms that we're talking about with brain rehabilitation. Now, what's exciting to me is that there's still so much research being conducted and being done. And they're looking at some of these mechanisms, and I'm sure you've seen them from a consumer standpoint, about what's actually being done for these individuals. When we're looking at concussions, traumatic brain injuries, and subsequently even neurodegenerative conditions as well too. So I hope you were able to take something away from that lecture and realize that while the eyes are a window into the brain, there is so much more to be understood and to be integrated together with therapies and rehabilitation. And regardless if you are a provider, if you're a patient, or if you're in school and you're still learning about that, what I'm going to tell you is this field is moving so fast that it's okay to feel overwhelmed and feel like you're not up to date because I feel like that most days of the week. But what I'm going to tell you is that the people that are in your office and the people that you're interacting with who are dealing with these injuries, they're not stuck and they're not broken. There's always an opportunity to improve their quality of life in some way, shape, or form. And I hope to be a part of that movement, like the North Dakota Brain Injury Network, which is empowering caretakers and providers to be able to do that for individuals who are struggling with these issues. So, without further ado, if there are any comments or questions, I'd be happy to field them. I'd have a hard stop at 3 o'clock, so I've got however many minutes to be able to take that. But I hope everybody was able to take away some information and have something that's at least actionable for them to be able to walk away from.
Okay, I got one and I'm gonna try to say these words, all right? I was recently decompressed with Chara malformation. Is this considered a TBI, and any suggestions on how to help reduce migraines with alternative therapies?
So I think, Carly, can you just ask that again? I think it's a Chiari malformation.
Chiari, yeah. I was recently decompressed with Chiari, or I wonder if they meant diagnosed.
Well, it could be both. They could have had a procedure done where they would shave off
Oh,
parts of the foramen magnum that would allow the Chiari to be able to move smoothly.
okay. So yeah, two surgeries, she said. Is this
And could you just
considered a TBI, and how can I reduce migraines?
Yeah, let me just see here. Yeah, Vanessa, that's a great question. So for those of you who don't know what a Chiari malformation is, the cerebellum, this little chunk of tissue that hangs on the back part of your skull, the cerebellum, essentially there's a bottom part of it called the cerebellar tonsils that protrude through the foramen magnum, which is the big hole in the base of your skull. And a Chiari malformation essentially is where those tonsils go through, and it can cause an array of things. It can cause migraines, it can cause balance issues, digestive dysfunction, you name it. Chiaris are just really interesting. Um, Vanessa, the procedure that you had was probably to allow the Chiari to be not so pinched, right, in the foramen magnum. The question is what to do about it, right? So now that you've had the procedure done and you've kind of alleviated some of the pressure, you can get like kind of like hypertensive or like increased intracranial pressure if those aren't relieved. The question is what to do about it. And what I can tell you is, confidently speaking, I'm not really sure. Okay. There could be issues where you're dealing with visual problems and visual dysfunction. You mentioned that you're dealing with migraines. There could be some sensitization of different neural pathways going on in the central nervous system that are causing those as well too. How do you unwind those is the question that I would ask. The other thing you have to look at as well is the fact that is there any like underlying inflammatory responses that are occurring? If you have a Chiari malformation, you've probably had it, I'd say, for probably most of your life. But how long has that been affecting your nervous system in some way, shape, or form? That's the question that we would need an answer to. But I can't answer the question, to be fair, without having like a proper bedside examination, right? I would once again coming back to what I was alluding to earlier, the inputs have to match the outputs. And so you need somebody to look at you structurally, look at you neurologically, and really assess to see, what's working well and what isn't working well. And then that would kind of guide your therapy and rehabilitation. So Vanessa, hopefully there's somebody close by who can work with you and treat you. I think that that would be probably the first step for me is I would say get an examination done by somebody who is really informative and understands what they're looking at. And then hopefully they can give you some neurorehabilitation to be able to kind of get you back on your feet and get you in a better spot. So hopefully that answers you, Vanessa.
I did throw your link in the chat to the neural connection too, if you
Lovely.
can, or if you wanted to try to go see that.
Yeah, for anybody who has, like I said, who has questions or we're always doing consultations wherever you are in the world. Like I'm always willing to talk to somebody, and if there's ways that we can help you, great. If not, then I'm happy finding someone else who can. So we have a great network of docs around the US and around the world who are really interesting and really smart. So always open to that. But more importantly, too, I think education is so powerful. So hopefully people are able to take away some take away some action items and understand really kind of what's going on with brain injuries because I think that they are quite elusive. And more importantly, too, we're just beginning to scratch the surface about what's actually going on with them. We still have a lot of work to do.
You got a question, does insurance cover any of your services like Medicare?
Medicare hasn't covered our services, but other types of insurance has. Yep. So just depends on the insurance network that you have and kind of what's going on with that. So always open to discussion on that.
Lots of people just saying thanks for your time and very good information. I would echo what they're saying. I'm gonna steal some of your lines there. Your frontal lobe is the VIP suite. I like that one. I like that one.
Happy to hear it.
Anyone else have questions though? Okay, back. I did throw our concussion symposium link in the chat. Dr. Reese's colleague, Dr. Hennis, is going to be presenting at that, along with a lot of other great speakers. And it's a full day of speakers and all free and CEUs for a lot of disciplines. So join us if you can. That's on September 13th, which is I think we had to move it a week earlier. We usually try to hold it on World Concussion Day, but we're all in Eugene, Oregon for National Association of State Head Injury Administrators State of the States Conference. So we had to push it a week forward, but September 13th this year. Please join us. I don't think I see any other questions. I really appreciate your time.
Yeah, absolutely. I'm very grateful to be joining, and hopefully, like I said, hopefully everyone was able to take away something that can have a little bit of a different perspective on what they're doing with these populations. So,
Sure, definitely. All right, everybody have a great day. I hope to see
thank you.
you next week or week after next for the next one. Thanks, guys.